Hi, everyone. Thank you for coming. My name is Dana Friedman. I am a 13-year papillary cancer survivor, and my son is a 1.5-year survivor. I'm here to introduce Sonya Khan. She is an endocrinologist and assistant professor at the University of Texas, MD Anderson in Houston, Texas, in the Department of Endocrine Neoplasia and Hormonal Disorders. She is also the Center Medical Director of the Endocrine Center. She did her residency in internal medicine, followed by the fellowship at the University of Texas Science Center in Houston, Texas, and trained at MD Anderson Cancer Center during her fellowship. Her current outpatient practice includes diabetes, thyroid cancer, pituitary disorders, bone health, hypercalcemia, and immunotherapy-induced, and I'm going to say this wrong, endocrinopathies in the oncologic population.
Thank you so much. That was pretty close. Endocrinopathies. I know we like to use big words, right? Job security. So thank you guys so much for coming. This is actually my first ThyCa conference. I'm really quite impressed by the conference and the topics and the participation both online and in person. So this is really a great opportunity. And I thank the board and Gary Bloom for inviting me to come to speak here. I'm excited to bring this topic to you guys because this is something that I commonly speak to patients about almost on a daily basis. And I thought it was really pertinent to the current times. Just wanted to really look at what the data is and share with you guys what our current recommendations are. All right, so I'm going to try to run 2 screens here, so hopefully won't be too complicated, but the objectives of this talk. So we're going to talk about obesity and cancer connection, discuss some medical and surgical treatments for obesity, the mechanism of action of GLP-1 receptor agonists, which are one of the most popular pharmacotherapies for weight loss, the clinical effects of these GLP-1 receptor agonists, GLP-1 receptor agonists in animal studies, GLP-1 receptor agonist and thyroid connection, and then our clinical guidelines. And so again, GLP-1s, which I'll talk about what they are our they are one of the pharmacotherapies that we use for weight loss. Okay, so this is a very nice graph to show us that, of course, obesity is an epidemic. Okay, this is from 2018. And obesity is defined by BMI. And I know there's a lot of discussion whether or not BMI is a great calculator, whether or not it's very accurate to show us, whether a patient is obese or a person is obese or not. But that's the best measurement we have. So how do we calculate or how do we define obesity? Well, overweight is a BMI of 25 to 29.9. Obese is a BMI of 30 or higher. And then severely obese is a BMI of 35 or higher. So this, like I said, is a graph of the US in 2018. And as you can see, Texas, where we're from, I know all of you guys are from all over, is orange. And even though, a lot of people love to say orange is great because UT, it's not great on the graph. It's 30 to 35% of the population is obese, okay? And our neighbors, Louisiana, they're maroon, greater than 35%. Now, I want you to look at this next graph here and see what the difference is. You can see a lot of the states have joined Texas and they've become orange as well. And their percent of obese population that are obese has increased substantially from 2018 to 2024. And we estimate that actually this will continue to increase in the next 5 to 10 years. And because of that, it's very important that we identify these patients and we mitigate their risk and we really focus on treatment, which we'll talk about in a second. So if you look, Colorado and DC somehow have continued to stay green. So it might be because of the beautiful Colorado mountains, and DC, there's a lot of walking there. So I don't know. Those are my theories and nothing based on science, but I just saw that last night. Thought that was interesting. All right. So it's been well reported and studied that being overweight or obese increases your risk of cancer. And because of that, again, it's very important to identify these patients and treat them with a multi-tier approach. These are 13 cancers, and there are more that are associated with being overweight and obese. Anything from kidney cancer, uterus, ovaries, pancreas, and what we're interested in, the thyroid, including gallbladder, upper stomach, colon, and rectum. So this is from the CDC website. So what do we have in regards to our obesity treatment tools? Okay, this is what we think about when we see our patients. So our first focus is always lifestyle and diet. Okay. We always talk about diet. What are you eating? What's happening in the kitchen before what's happening in the gym, right? And that's really the cornerstone for the approach. Without that bottom lifestyle modification, without the diet, nothing else is going to work. Okay. You can't do one without the other. The next step is pharmacotherapy. So that's always been our second line. And we combine it, of course, with lifestyle modifications and with good diet. And there have always been different medications that have been around for weight loss. But in the last 5 to 10 years, we've been able to offer patients more options, not only for weight loss, but also for diabetes management and glucose control. So there have been a lot of new pharmacotherapy in the last 10 years, which has been exciting for endocrinologists and our patients. The third would be surgery. So surgery, including anywhere from gastric sleeve to gastric bypass. And, there are BMI targets that we use to recommend patients. We also look at, do patients have complications of their diabetes, or excuse me, of their obesity, or any kind of obesity related complications. So that kind of guides us as to which patients are surgery candidates. But today, again, we're going to focus on pharmacotherapy, and we're going to discuss a particular class of drugs, the GLP-1 receptor agonists. And so you've probably heard about these drugs. That's why you're here. And they've actually been around for almost 20 years. But in the last 5 to, I would say about 5 years, it's become very, very popular, not only because of their great benefits and the great trials that have come out, but also because of celebrities. So these are the common GLP-1 receptor agonists, okay? So some of you may not be aware that there's so many of them. So dulaglutide, which is marketed as Trulicity, exenatide extended release, which is Bydureon B-Size, exenatide Byetta twice daily, liraglutide, which is Victoza and Saxenda, which are daily, semaglutide, which is the most popular one these days, Ozempic and Wegovy weekly, semaglutide, which is also oral, Rybelsus, and then tirzepatide, which is our newest one, the GLP-1 receptor agonist, but also is a GIP receptor agonist, is marketed as Mounjaro or Zepbound. So what exactly is a GLP-1? GLP-1 or glucagon-like peptide 1 is a second incretin identified in 1983. It's a 30 to 31 amino acid long peptide, and it's secreted by 3 tissues in the human body: in the L cells of the distal intestine, the alpha cells of the pancreas, and the central nervous system. And with its interaction with the GLP-1 receptors, it regulates glucose homeostasis. And the half-life of these the half-life of the natural GLP that we make ourselves is very short. It's like 1 to 2 minutes, depending on the species. But these are synthetic GLP-1s, and so they last longer in the body. Normally, they're broken down by DPP-4, which is dipeptidyl peptidase 4 in the body. But these are synthetic, so they stay around longer. And because they're not degraded, they can be given in a weekly formulation, okay? So these drugs have emerged as great glucose control drugs. And in the process, we found out that they're great for treatment of obesity, treatment for weight loss, and they actually have a lot of multi-tissue benefits. So with the success of glucose control, they were then approved for weight loss. So these are the GLP-1s that are approved for obesity management. So you have liraglutide again, but it's marketed as Saxenda, and semaglutide as Wegovy, and tirzepatide as Zepbound. They're marketed under different names, and they're also at higher doses, okay? So for obesity, it's actually approved at slightly higher doses. So how does a GLP-1 receptor agonist work? So GLP-1 receptor agonists, okay, which the GLP-1 hooks onto those on these receptors. These agonists have been shown to significantly improve glycemic parameters and reduce body weight. And what they do, they actually work in the pancreas. They increase insulin, they decrease glucagon, but then they work a lot of other places. So they work on appetite and satiety in the brain. They increase myocardial contractility, and they also increase endothelial function. They decrease arterial stiffness. They decrease liver fat, inflammation, insulin resistance. So they're working all over the body. So when we're giving these GLP-1 receptor agonists, you know, in our head, we're thinking, oh, this is good for glucose control. And yeah, you'll get a little weight loss. But actually, there's a lot of different benefits that are happening with the GLP-1s. And that's what really makes the GLP-1 receptor agonist stand out and so successful in our patient population. So what are the other significant benefits? And this is actually the best thing about the GLP-1 receptor agonist. Though our patients would say, no, it's the weight loss, this is really what it is. So due to the metabolic regulatory functions of the GLP-1 receptor agonist, they have been considered for the treatment of other diseases. So of course, obesity, but also liver disease, other metabolic diseases as well. So you actually get reduced blood sugar. So we know that 0.8 to 2.5% reduction in the hemoglobin A1C, weight loss, 10 pounds to 35 pounds, and actually even higher, up to 30% body weight with tirzepatide. Decreased triglyceride and reduction in non-fatal strokes and all strokes by 16% compared to placebo. And then most recently, we've had 3 really amazing trials, the LEADER trial, the SUSTAIN trial, and SELECT trial, which showed a decrease in MACE. MACE is major cardiovascular events and reduction in cardiovascular all-cause mortality and reduced hospitalization for heart failure. So not only are we getting glucose reduction, weight loss, decrease in risk of stroke, we're also getting decrease in this all-cause mortality for cardiovascular events. In addition, we've seen improvements in renal outcomes, which is decreased progression of kidney disease and decrease in progression of MASH, which was formerly known as NASH or non-alcoholic fatty liver disease. But what are the side effects? So let's say we give these to our patients. What can we tell them that they can expect? The most common are going to be GI side effects. Okay, you can get nausea, abdominal pain, discomfort, vomiting, diarrhea, constipation, and gallstones. You can also have symptoms of pancreatitis, which are severe GI symptoms. And, you would basically have similar symptoms, nausea and abdominal pain, but they would be very severe. And we would have the patient stop the medication and we would draw labs to look at those pancreatic enzymes. Of course, if someone had severe or persisting symptoms, they would require the GLP-1 receptor agonist to be discontinued and a diagnostic workup would be indicated. The other caution that we have actually been investigating over the last couple of years is when to hold the GLP-1 receptor agonist. So when undergoing a procedure requiring any anesthesia, the recommendation is to stop 1 to 2 weeks prior to avoid risk of aspiration, as the GLP-1 receptor agonist slows gastric emptying. So it actually on the gut, when it works on the gut, what it does is it slows that carb absorption. And so you feel fuller when you normally wouldn't. But then the gastric contents stay in the gut and the intestines a little bit longer. And because of that, when you get anesthesia, there's a risk of aspiration. So right now, the recommendation is 1 week. They're looking at maybe extending that to 2 weeks, but that's still really under investigation. Now, do patients have these symptoms forever? Occasionally, you'll have these symptoms, and then after a few weeks, they do get better. If they don't get better, we let you stay on the lower dose longer to really see if you can if those symptoms will go away. And every time you increase a dose, you may get these symptoms again. So yes, they can come back. And most of the time, most patients do really well. But these are the things that we really warn them about. So what does this GLP-1 receptor agonist have to do with the thyroid? That's why you guys are here, right? So what is the thyroid cancer connection? So we know it's a good drug. We know it does great things, but what does it have to do with the thyroid? So let's look at the thyroid on a cellular level. That's really important to understand if we want to understand the connection. So there are follicular cells, which secrete thyroglobulin, and then there are parafollicular cells, which are also called C cells that secrete calcitonin. Okay, so the thyroid is made up of these 2 types of cells. So they have different jobs. Okay, the follicular cells produce T3 and T4, which is of course involved in many metabolic processes, the ones that we're most aware of. Regulation of weight, energy levels, internal temperature, hair, skin, growth, and metabolism. The parafollicular cells actually produce calcitonin, and that's involved in calcium homeostasis. So different jobs for different cells. So to understand the connection, we also need to review the types of thyroid cancer, okay, and where they originate from. So first, the frequency. Papillary thyroid cancer is 85% of thyroid cancer patients. Follicular thyroid cancer, about 12% of patients. Anaplastic thyroid cancer, less than 3% of patients. And medullary thyroid cancer, 1 to 2% of the population. So papillary, follicular, and anaplastic cancers are cancers involving the follicular cells. Medullary thyroid cancer is a cancer involving the parafollicular cells or C cells, and that's the most important to understand the connection. So now that we understand the cellular level, right, we understand there's follicular cells and we understand there's parafollicular cells and they make different cancers. Let's remember where the GLP-1 receptors are located. Okay. Again, they're located in many areas: the brain, intestine, heart, liver, adipose, muscle, pancreas, stomach, and the thyroid. But within the thyroid, they're distributed in a different manner. So they're not all distributed the same. Okay. So not everything is created equal, as they say, right? So now to the C-cell connection. Now what you guys are waiting for. GLP-1 receptors are found in about 5% of normal follicular thyroid cells and up to 18% in papillary thyroid cancer cells, which are follicular cells as well. The GLP-1 receptors are expressed heavily at about 30% in C cells or parafollicular cells. Now, medullary thyroid cancer is caused by the neoplasia of C cells. So there's a concern that if GLP-1 receptor agonists are causing hyperplasia of the C cells, and the C cells then will lead to an increased risk of medullary thyroid cancer. Okay. So what do we know in the studies? What have we seen? So evidence from rodent studies suggests that the GLP-1 receptor agonists may stimulate parafollicular C cell proliferation, okay, potentially affecting the risk of new onset medullary thyroid neoplasms. This is where the data first came from. So in rodents, the GLP-1 receptor agonist does cause C cell hyperplasia and neoplasia. It also increases calcitonin secretion. There's an increase in a dose time dependent manner. So the longer you use it, the more hyperplasia and neoplasia. The higher dose you use, the more hyperplasia and neoplasia. And then they found that rats actually have an increased hyperplasia and neoplasia when compared to mice. Okay, so what does that mean about humans? So this effect of C cell proliferation or neoplasia by GLP-1 receptor agonists, they're not documented in non-human primates or in humans. So the thought is that the proliferation of C cells may be rodent specific. Okay. They looked at monkeys. So what did monkeys show? Studies in monkeys did not identify the effect of GLP-1 receptor agonists on thyroid C cells, no increase in the cell size, and no increase actually in the thyroid weight. So one explanation could be that GLP receptors are in lower numbers on C cells of non-human primates and humans compared to rats and compared to mice. So one of the first studies to look at it was a European study. It looked at 236 out of 11,243 cases of thyroid cancer. And these were patients who used GLP-1 receptor agonists. This study actually showed a slight increased risk of all type thyroid cancer with GLP-1 use. And this was in April of 2020. Then the French case control study came out, and this was later in 2023 in Diabetes Care by Bezin et al. This was a nested case control analysis within the French National Healthcare Insurance System. This was using diabetics or including diabetics between the years of 2006 and 2018. They compared the use of GLP-1 receptor agonists versus using another second-line anti-diabetes drug. And the findings with this was that there was an increased risk of all thyroid cancer and medullary thyroid cancer with GLP-1 receptor agonists from 1 to 3 years of treatment. Now, there was an explanation of the French case study, okay? There was a detection bias due to the increased incidence of thyroid cancer yearly. So there has been, as you guys have probably heard in every talk, an increased incidence of thyroid cancer over the years substantially, exponentially. And that some of that can be because we really have a great ability to use our ultrasounds and our CAT scans to really detect these very small papillary thyroid cancers. But this study was really measuring relative risk. It wasn't measuring absolute risk. And when they looked at the p-values, and p-values are what you use to determine statistical significance, they actually didn't find less than 1 year significant and more than 3 years significant. So they thought that's a problem with the study, because you would assume that if a patient used it for 10 years, that they would have a higher risk, but that wasn't the case in this study. So you can imagine, if you look at imagine a study. So we're looking at the effect of a new drug on a rare effect. So if the study finds a relative risk of 2 for this side effect, it means that the people taking the drug are twice as likely to experience a side effect compared to those not taking it. But because the side effect is really rare, the absolute number of cases is very small. So there were a lot of, really kind of complaints of the study, or, many people looking at this and saying, this does not look like a good study. So let's look at this again. So then we looked at semaglutide and cancer, and this was a systematic review and a meta-analysis, and this was of 37 studies with 46,917 patients, and they were analyzed on semaglutide. What did they find? Pancreatic cancer incidence was not increased with semaglutide. Thyroid cancer incidence was not increased with semaglutide, and all neoplasm incidence was not increased with semaglutide. The next one looked at the Korean National Health Insurance Database from 2014 to 2020. And this actually had two distinct cohorts to compare patients who are on a GLP-1 receptor agonist and patients on SGLT2 inhibitors. And SGLT2 inhibitors, if you're not familiar with those, that's just another class of diabetic medications that in the past has had a previous non-association with thyroid cancer. So they were comparing those two cohorts. Cohort 1 is 21,722 patients taking the GLP-1 receptor agonist versus 326,993 patients taking SGLT2 inhibitors. The second cohort was 904,300 patients taking the DPP-4 inhibitors versus 112,017 patients taking SGLT2 inhibitors. And what did they find? No increased risk of thyroid cancer in individuals with type 2 diabetes using the GLP-1 receptor agonist, and no increased risk of thyroid cancer in patients using the DPP-4 inhibitors. So there was another Scandinavian cohort study in April of 2024 in BMJ, and this one looked at 145,000 patients taking GLP-1 receptor agonists and 290,000 patients taking DPP-4 inhibitors. And this was between the year of 2007 and 2021 from a nationwide cancer registry. So the first cohort was patients on GLP-1 receptor treatment versus the SGLT2 inhibitors, like previously. The second was DPP-4 inhibitors versus patients on SGLT2 inhibitors. And again, they used the SGLT2 inhibitors because that was previously not associated with any increased risk of thyroid cancer. The mean follow-up time was 3.9 years in the GLP-1 receptor agonist group and 5.4 years in the DPP-4 inhibitor group. The GLP-1 receptor agonist use was not associated again with the increased risk of thyroid cancer, and the incidence of medullary thyroid cancer was also similar in the two groups. There was a narrative review that came out in Thyroid in 2024, so just this year, and this review of all the evidence concluded that evidence from randomized controlled trials indicate occurrence of thyroid cancer is infrequent in individuals exposed to GLP-1 receptor agonists. The previous observational studies were at higher risk of bias and yielded inconsistent results. So overall, there is no conclusive evidence of elevated thyroid cancer risk with the use of the GLP-1 receptor agonist. And these findings can, of course, help clinicians when addressing patients' concerns about a potential yet unproven link between GLP-1 receptor agonist therapy and thyroid cancer. So what do we actually recommend to patients? So of course, we use the GLP-1 receptor agonist in diabetic patients. We're also using the GLP-1 receptor agonist for weight loss in patients who meet the following criteria. If they're overweight with a BMI greater than or equal to 27, plus complications, so hypertension, diabetes, or hyperlipidemia, or if they're obese with a BMI greater than 30. GLP-1 receptor agonists are okay to use in patients with history of papillary thyroid cancer, but they are contraindicated in patients with medullary thyroid cancer and a history of MEN2 due to the medullary thyroid cancer incidence. They're also contraindicated in patients who have had a history of pancreatitis. So really more randomized studies are necessary to further elucidate the question of risk. However, we know the advantages, both related to cancer and related to weight loss. So what are the take-home points? So GLP-1 receptor agonists are useful drugs along with lifestyle modification for both diabetes and obesity management. They are, however, contraindicated due to the rodent studies in patients with MTC, medullary thyroid cancer, MEN2 syndrome, due to the incidence of medullary thyroid cancer, and patients who have had a history of pancreatitis. GLP-1 receptor agonists are also okay to use in patients with papillary and follicular thyroid cancer. But of course, more studies are really needed to understand long-term thyroid cancer risks. And here are my references if you guys want to look at them. And I am going to open it for questions. I know this wasn't a really long lecture, but there's actually not that many studies. We have the ones in the recent years, but this is the evidence we have so far. And currently at MD Anderson, we are using these medications in our thyroid cancer patients when it is approved for them, of course. And it's been a really good adjunct to lifestyle modifications and diet for the patients that qualify. So I'll open it to questions.
Okay, I'm Jeff Woloff. I'm the virtual host. I have two questions. One question is from Tracy Edwards. She's been on Zepbound. I'm sure I'm not pronouncing it correctly, for 5 months, and she's lost 40 pounds. But it seems that she's slower than other people. She's 1 year out from total thyroidectomy for papillary and 11 months from radioactive iodine.
Mhm.
Her BMI went from 43 to 36.6. She wants to know if she's slow due to the papillary history.
So that's a really good question. So we have noticed there are patients who are better responders than others. Okay. So there are patients, because a lot of patients will come in and they'll say, listen, Dr. Khan, you put me on this medicine, but my friend has lost 50 pounds and I've lost 5. And why is that? So we have noticed actually that some people respond to certain GLP-1s better than others, and also that some are better responders in general compared to others. So you may actually put a patient on, which is the lowest starting dose of Ozempic, the 0.25, which normally you won't even see much results from that. And they may already start to lose weight, versus you may have another patient who gets up to the 1 milligram, which is then the third step. And they may only lose maybe 5 or 8 pounds, and so we know there are patients who are responders to certain GLP-1s better than others overall as a class. But sometimes what we can do is we can change the drug. So if you're not having a great response to, let's say for this one, it's for obesity management. So it would be Zepbound and you actually said it correctly. So if you're not having a good response to Zepbound, maybe we try Wegovy for you. And so oftentimes we'll do that. There's also a thought that there may be some development of resistance to these medications as well over time. And that's going to be something that we're really going to have to figure out what we're going to do. At this current time, what we do is if we feel like you're not doing well on it or it's not giving you the benefit you need, we try to switch the drug. But as patients are continuing to use them longer and longer, we're going to have to come up with a better algorithm of how to change this and how to really manage that for patients so they don't gain that weight back. I hope that answers it.
Okay, I have a question for myself. I donated one of my kidneys back in 2008. I am obese. My BMI is definitely over 30. I think it's over 35. I'm not too sure. I want to find out which of the drugs is kidney safe.
So actually all of them are kidney safe, which is really great. So we don't have to adjust for kidney function. So you can actually use any of them. And that's really one of the greatest things, not only for obesity management, but also for our diabetes management, because a lot of our diabetes patients have renal or kidney complications and decrease, as you guys probably know, GFR filtration rates. And so we're able to use these drugs. So any of these would be safe for you.
Okay, thank you. And I have 3 other questions so far.
Sure.
From Anthony. Have there been any studies about how the slowed down emptying of the stomach associated with GLP-1 AR drugs impact levothyroxine absorption?
So definitely we have seen it in practice. Now, is there a study out there? There might be, and I'm not aware of it. I have not heard of any. But it definitely does affect it because we do see that patients have been started on GLP-1s and there's an issue with their absorption. But the greatest thing about levothyroxine is, or Synthroid, we can change the dose to account for that. So the the one thing that I always do, not really because of the absorption, but because of the weight loss that you get with the GLP-1 receptor agonist, is I always tell patients, if you lose, 10 pounds, I need you to message me and I need to do your labs again, because levothyroxine and Synthroid is a weight-based drug, as many of you guys are aware. And so when someone's on a weight loss drug, we're hoping that they're going to lose weight. And so the dose may need to be adjusted. And is some of that adjustment because of the absorption change? It's possible. Now, has there been a study? I don't know about it if there has, but I will look today.
Okay, next question. If I already have MTC stage 4, what might be the harm in taking a GLP-1?
Number one, they're contraindicated. So it's not going to be, you're not going to be able to get it prescribed. The harm would be that if, if there is a connection that we don't know, even though we haven't seen it in human studies, the recurrence of that MTC or the growth of that MTC would would affect your mortality, right? So that's more dangerous for you. Your MTC is more dangerous for you than actually the obesity or the weight. So when we look at benefit risk, we always have to look at benefit risk, right? Everybody wants to lose weight. We all want to be 5 to whatever, 20 pounds lighter. Everybody always says that, right? But then what is the benefit and risk, right? Yes, there are a lot of great benefits, but then when your cancer is the bigger on the higher stage, we have to look at that first. So number one is contraindicated, but number two, the risks do outweigh the benefits for that.
Okay. Another one is from an anonymous. This is why I feel so skeptical. The lack of long-term studies. Do you know of any in the works currently?
There are a lot of studies and meta-analysis that are probably going to come out in 2025. This is something ongoing. I mean, as we use these drugs more and more, as we get more data, these are likely to come out in the next couple of years. So I think that is only continuing. We're continuing to look at these drugs in our cancer patients as well. A lot of our pancreatic cancer, for example, patients want to use these drugs, and currently we are not using it in pancreatic cancer. And we're not using it, of course, in medullary thyroid cancer as well, even though the studies right now for pancreatic cancer do not show increased risk. We're not using it in those patients because there are some receptors there, and we don't know. We don't know what could happen. And again, the cancer is the bigger problem. So we don't want to add something into there that can then cause an indolent cancer to then become aggressive. So yes, there are lots of studies that are going to come. And I think, I was just thinking of that. I'm going to save this talk and add on to it next year, because I bet there's going to be some good stuff that comes out in this next year. But the patients that we are using it for, the diabetics that we are using it for, and the non-diabetics for obesity, right now we're seeing really great cardiovascular data, really great kidney data, really great blood sugar. And, lots of patients are able to walk comfortably for the first time, or start running for the first time, or start jogging for the first time, because of this weight loss. And those things overall affect their life, and that benefit for them is higher than the risk at this time.
Okay, one more question. Are these GLP-1 drugs something a post-thyroid papillary cancer, full thyroid removal, something can take short-term to get back to pre-cancer level and then get off of it, or how long is the drug recommended for?
So it's a really good question. This is actually the conundrum, I guess you can say, that we're in right now, right? We're starting patients on this great drug, and then actually the problem we're having, it's not medical, it's insurance. And a lot of times patients' insurance changes and they can't use the drug. And so then we're left with, okay, what do we do? What do we put them on? And are they going to gain the weight back? When you stop the drug, you are going to gain weight back. Okay, this is the truth of it. So right now they're not recommending stopping the drug, but I know that there's going to be a time when somebody changes their insurance, or they lose their job, or something happens. So when I put patients on GLP-1 receptor agonists, I really tell them, listen, you are going to have to look at your meals and see what you're eating, how much you're eating, or have to start putting it into your mind that this is how much you need to continue to eat. And you need to go to the gym. You need to be doing weight-bearing exercises. You need to start making this a huge lifestyle change, because there may be a day that you have to stop it, whether you can't tolerate it, whether your insurance doesn't pay for it, or whether you just want to come off of it. And yes, you may get some weight gain, but they're really looking at what regimens can we put patients on to decrease that weight gain when they come off. Do we
Right.
have an answer right now? No. But we're all trying our best to really prepare patients. So I always try to prepare patients for the what if your insurance doesn't pay. And that happens all the time. So we are really trying to really, get the point across that this is a great drug. And yeah, it's fantastic that you don't have to really think about it. It sort of makes you eat less. But if you're not really thinking about it, then when you don't have it, it's going to be a big problem. So you don't want to gain that weight back, because emotionally and psychologically and for your body, it's very tough. And if anyone has dealt with, diet or weight gain or weight loss, I always joke, but it's not a joke. I mean, I've been on a diet since I was in kindergarten, probably. It's like you never want to regain that weight, right? So what can you do to prevent that weight regain? And so that's what we're doing for our patients in preparation for that.
Okay, I have one last question so far. I have AFib and have experienced some issues with increased heart rate as I have increased my GLP-1 medication, Ozempic. Any evidence of heart issues?
It should not affect the heart in that adverse way. I don't think there's probably any connection between the GLP-1 and the heart rate. It actually has great benefits for the heart. So I don't think that that's the cause. I would really investigate further with the cardiologist and see what could be causing that.
Okay, I want like one last comment. Is that's half the battle, whether you, with your weight loss drugs or without them, half the battle is the portion sizes. We're so used to having huge portion sizes. That's the whole problem. Now, when you got to cut down, it takes a while to get used to it.
Yeah, absolutely. Absolutely. It's funny when you travel to other countries and you get like a meal, or you go to a really like nice restaurant and you're like, that's all I'm going to get. That's probably how much we should be.
Exactly.
Okay, so I have been on semaglutide since December and have lost 50 pounds. I believe that the first 10 pounds were kind of gravy, but then it is 100% exercise and diet change. And I realized that when I decided to go with this drug, it was a forever thing. And I am paying out of pocket. So I'm anxious I've got a couple comments and questions. First off, in that 50-pound weight loss, my TSH has not changed.
Good.
So it stayed the same. I would love to no longer do injections. How do you think that there will be a pill maintenance form eventually? And because I've done so well with my diet and exercise, should there be a time where I do have to go off of it for whatever reason? Because I've really changed my diet and exercise, how much of a weight gain would I see no longer taking the drug?
So that's a really, really good question. First, congratulations on your weight loss. That's fantastic. And you're right. Some of it is the medication and a lot of it is your hard work, right? So really building those habits and going to the gym or doing it at your house, whatever you like to do, and really looking at your food and reevaluating. So a lot of it is that, not just the medication. So really, really good job. Now, is there a maintenance oral form? There is an oral semaglutide, which is Rybelsus. Does it work as well as the injectable? No, but I mean, it is a possibility. So what we do for patients is we'll say, okay, whatever dose you're on, we can either drop your dose, see how you do for a while, really give it like 6 months or give it a year, and then we drop again, or you can switch to the oral and see what your results are. And if not, you can go back to the injectable. Cost of oral may be a little bit lower than the injectable, which is always a good thing to know when you're trying to switch. But at this time, there is no necessarily different maintenance. It's really to stay on the medication at the current time. I would say probably in the next 5 years, we're going to come up with something different. And there are a lot of things in the pipeline at this time. So right now, I would say if you wanted to try to decrease, which is what we're doing with a lot of our patients, once they reach their goal weight, we're just dropping them one dose and kind of seeing how they do, see how they because you will get that increase in appetite when you drop the dose a little bit, and they have to learn how to deal with that increase. And it's really that's really the hardest part, is that increase. Because even if you miss your dose, you might notice if you miss your dose for like 3 days, 4 days, you'll see that you have like a little stimulation of your appetite that you may not have had. Now, not everyone has it. Again, different responders react different ways. But you can. And so we really want people to say, okay, well, I got this increase in appetite. This is how I'm going to deal with it. I know it's the medication drop, and see how they can handle it before we really try to take the drug away. Oh, not really right now. No, not really. I mean, this is something that is being advocated, at the state and national level for patients, because not only do we, there are other indications for this drug for polycystic ovarian syndrome patients who have like a pre-diabetes like syndrome, for patients with pre-diabetes, to decrease their risk of development of diabetes. But getting it approved for those patients, I mean, sometimes we can get it. We try very hard, but it's not easy. And so we are fighting for it at a national level, but it's going to take some time because they are expensive drugs, and patients are at this time, willing to pay for them out of pocket. So that's big pharma. So, but hopefully we have hope that they will become a little bit more affordable, and then also that our we're advocating for it. So hopefully things will change. Yeah.
Oh, it's been worth every penny.
Yeah, you're investing in your health, right? That's what I always say.
Well, I haven't had the results that you've had, but I haven't been on it that long either. But I'm doing tirzepatide. So I want to know how you feel about microdosing, because I have not titrated up to the next dose,
Mhm.
and it's coming off just slowly, but there are also no side effects. And I wanted to mention one other thing. There was one benefit that you didn't mention that I've really noticed. It helps a lot with like anxiety or depression. Amazing. So for that reason, I'm thrilled with it. But just was curious what your thought was about just going low and slow and taking it off.
So there's a lot of benefits to going low and slow. One is that some people are really great responders to even the low dose. And the less you use of anything, the less you put in your body of anything, the less risk you have for any complications or side effects. And Zepbound or tirzepatide is actually tends to be a little bit more, tends to have a little bit less side effects. So patients tend to like that medication a lot, especially if they couldn't tolerate other medications, or other drugs in that class. So I am great with low and slow, and we do it for a lot of patients. And that's probably why you haven't had 50 pounds, but that's okay. That's good for your body. And you actually touched on something really interesting. So they have found that there have been some improvements in patients who have anxiety or OCD-like tendencies, eating disorder tendencies, some improvements. So that those receptors on the brain may be doing something additional for our patients, which is really great. So, I mean, this is a really great class of drugs. We just need to really study them a little bit more and continue to put that effort.
I use Majori. I was on an S-metric one time, but was having a hard time getting a hold of it because I'm diabetic, and that's why I'm using it. And I haven't been losing that much weight with it. Been still having a hard time getting a hold of it because people are using it for losing weight, which I mean, it's not bad, but it makes it hard. My insurance is paying because I'm doing it because of my diabetes. But my question is it worth it really? And that, is there something else with diabetes? And that, I think with I'm taking my, there's with my Synthroid, they're trying, it's high because it's trying to suppress. I don't know if that's making a difference. And I'm not sure if it's worth it now with I mean, it's great. You guys use it. It's fine. And you're paying for it, but it makes it harder for the ones that really actually need something to suppress and that. And I don't know if it's even worth it because with all the other things and that, I mean, if it's helping you, that's great. But I don't, is my synthroid being high, is that making a difference on this? I can't get my doctor even tell me why. And that he just says, you need to have this. And I did also do Synjardy and that too.
Mhm.
And that, but I'm not sure it's worth it. And that, I mean, find other ways to maybe do it, lose weight. And then with our, I have thyroid and on my follicular and it's metastasized, which I mean, it's been for years. I've been dealing with it now for 13 years now, but it's kind of coming back and I'm not sure where it's at. So, but I haven't lost that much weight in that, but maybe it's because I'm not, you know, dieting as well as I should or exercising, but I haven't been feeling like I can.
Yeah.
And I'm just kind of frustrated. I'm not sure. And it's so.
I think the supply issue, well, I'm sorry to hear about your thyroid cancer. In regards to, is it worth it? I mean, it is a great class of drugs and it does, improve a lot of things more than just weight loss. You get, cardiovascular benefit and the kidney benefit. And even if you don't get a lot of weight loss with it, you get good glucose control with it as well. And it doesn't affect the kidneys in a bad way. And it works really nicely with Synjardy as well. So is it worth it? I would still say yes, but there is a hassle of trying to get it because of the supply. And it always makes me confused how they cannot anticipate supply because they know that everybody's going to want to use the drug. And there are indications for it, right? There's indications for weight loss, so those patients are getting it. There's indications for diabetes, so those patients are getting it. So it's if we wanted to give it to someone who it wasn't indicated for, we really can't get it. We can't even prescribe it at MD Anderson if you don't have those criteria. So we can't even off-label prescribe it like we can in like a private practice, for example. So we want to get it for patients. It is indicated for them, but we can't find it. But there is a way. I mean, what we do is we really work closely with the drug reps to hear when the supplies are going to be out, how long they're going to be out, and then try to switch you on drugs that are available. And that's why we do use different drug classes. Sometimes we'll use Mounjaro and then we'll use Ozempic and switch you around for that reason. It is a hassle to not be able to get your drug, and it should not be like that. But we learn how to deal with these things too. And, usually your doctors are hearing from their drug reps, like, okay, it's going to be available in January. And then we sort of work like that. I mean, I don't know. I feel like these drug shortages have happened more since the height of COVID. And that's really what's changed things. Whoever thought that car chips wouldn't be available, remember that? So it's just insane. So, I'm sorry you had such a hard time getting it. Is it a good drug? Absolutely. Can you do other things for weight loss? Absolutely. But hopefully they'll be able to get it for you if that's what you choose.
Hi, I don't take any of these drugs currently, but I'm considering it, and I have I guess 3 concerns. One is I'm trying to blank. Okay, so is there one? So previously there was the Wegovy and Ozempic, and now there's newer drugs like Zepbound that I understand is the active ingredient plus another drug combined, and then now I'm hearing there's going to be maybe pills in the future. Is there a good time to, or a better one to pick, or should you wait for something to be more available?
So the oral one is already available. It's actually been available for quite some time. I don't remember exactly the year it came out, but it's been available at least over 5 years. And is there a better one? I mean, I would say the injectables work the best. We're seeing really great results with Mounjaro, which is the tirzepatide. That one seems to work even more than the semaglutide. Supply is an issue sometimes. So, I mean, I would say, semaglutide or the tirzepatide are good options, whatever your insurance approves. And what I always tell people is I can tell you what I want to give you, but you need to find out what your insurance will give you, because that is part of, unfortunately, the American system of healthcare, right? So I always tell people, find out from your insurance what they'll cover, whether it's for diabetes, whether it's for obesity, because there's a difference. They may cover it for diabetes, but they may not cover it for obesity. So that's something to know, and that may help make the decision. But they're both great drugs, and you will hopefully get good results from both of them.
Okay, and then my second concern is, and you would disagree with me, I guess, but my previous perception of these drugs is it's an off-label use of it's the diabetes drug. So it's a serious drug that people are using to lose weight, and that's why it's not covered by insurance. So if it's now approved, why isn't it covered by insurance, or what,
Good
what I'm
question.
saying? Yeah.
So before, yes, we used to use it off label all the time. I wanted someone to lose weight. They were pre-diabetic. I don't want them to be diabetic because that increases their risk for everything. And that's actually good for your insurance company too, but they just don't think the same way doctors do. And so we would use it off label. It's very difficult to use it off label now. So now it is approved for obesity management. But the problem is not every insurance company has an obesity management clause. So in your insurance, in your policy, it has to say that they treat obesity and how they would do it. Is there pharmacotherapy in there? And that determines whether it gets covered by your insurance or not. So they may cover semaglutide, but only for the diabetics. Like I'd have to say my insurance only covers for diabetics and not for obesity. Used to be different, but they changed. And so they're rallying to change that again, but it's within your insurance clause. Can I get it approved for an obese patient? I mean, I can, but they'd have to pay for it because it's not going to get it approved by the insurance. So.
Thank you. And I had one other question, which was, you mentioned the thing about gastric absorption. And for someone who takes like something for like GERD or esophageal reflux, would that cause problems for that?
It usually doesn't. Actually, we have very few cases where we have the absorption issue. We have seen it, but then there's always that thought that maybe there's something else going on. There are patients that have really slow gastric emptying with the GLP-1 receptor agonist, but most patients, they may have some constipation, but it's really not to that degree. So most of the time, like I think you were saying, your synthroid wasn't changed. That's usually the case. That's the majority of the case. And other medications don't end up being affected at all.
Okay, thank you.
You're welcome. I think we have.
Thank you. This is very interesting. And I'm a nurse practitioner,
Oh.
so I've had the same questions as far as why won't my insurance pay for it? Why do the people with weight loss get it, but diabetics can't? And a lot of patients have turned to compounded medication. And what are your thoughts on that? The safety? I'm not sure what to tell my patients other than I can't recommend it, but what are you seeing with that?
Yeah, so that's actually a really good question. So with the compounded medications, number one, we're not sure what they're compounding it with. Okay. And so let's say patients with cancer, patients without cancer, right? For both patients, I don't recommend it. I say it's not FDA approved. We don't know what it's compounded with, especially in our cancer patients. I don't want you putting something in your body. We don't even know what it is. So not only are, we're using the GLP-1, but what else are we using with it? And is it even a GLP-1 receptor agonist? Because there have been some cases where these pharmacies or some pharmacies had been actually selling different things and saying they were GLP-1s, GLP-1 receptor agonists, that it was actually insulin or it was something else. So, I mean, you guys have probably seen that in the news where they've shut those pharmacies down. So actually, I was really curious because I have a very good friend who has a pharmacy, or sister has a pharmacy, and it's a compounding pharmacy. So I asked her, I said, hey, are you guys compounding it? Because if you are, maybe you can tell me what's in it and I can tell my patients and maybe we could use your pharmacy. And she said, no, we're not doing it because it is, there's really nothing great to compound it with that's safe and that's approved. And so, really my thing is, I know it's an expensive drug. I know it has a lot of benefits. Maybe things will change in the future, but right now let's use what's approved because that's what's studied.
Okay, thank you.
Quick question. How are these drugs working with patients that are on a ketogenic diet? And then secondly, is there any evidence that these drugs have any effect on the immune system or are effective at all in treatment in starving cancer cells of glucose?
So there are no studies that show, we'll start with the last question about for cancer, like helping cancer by starving cancer cells of glucose. There's no studies that show that. We're just seeing that there's no increased risk of cancer with the GLP-1s. How do they work with patients on a ketogenic diet? They still work. But it works by the trigger of glucose. So it may not work as well. The biggest problem I have with GLP-1s with patients who are on a keto diet is actually they can't tolerate the keto diet as well. Most of the time what they tell me is it's very difficult to take all of that protein because it's harder to digest with the GLP-1. Not everyone, but I mean, that is kind of, if I was going to have a complaint, that's what it is. So it will work, but they have more side effects is what I've noticed. So can we use it? Absolutely, but it's a little tougher for them. Honestly, that's one of the things with the GLP-1s is that carbs are the easiest to eat when you're on these drugs, which is not what we tell patients to eat. So I always counsel patients and I say, I know that you could probably eat like, something that you normally wouldn't want to, or like have juice or have, these sugared coffees that are so good, but that's not what you're going to do long term. So even though it may be easier in the beginning, you have to sort of find foods that you can tolerate. So it's a little bit more difficult, but it can be used.
Hi. I'm on larotrectinib and I'm involved with the NTRAC group. And a lot of us patients have gained a lot of weight since starting the drug. Are these drugs safe if you're taking targeted therapy? And then kind of the second part of the question is, you mentioned that your stomach the stuff stays in your stomach more. So would would the absorption of the NTRAC drug actually be affected? Good or bad?
So we don't know what the absorption, if it would affect that. I mean, it hasn't really shown to affect other drugs substantially. Like we haven't needed to change any doses, maybe occasionally Synthroid, but we don't know. Sometimes that's a plus or minus with patients because there are a lot of other factors. So we wouldn't know about absorption. Now, do we start patients on it when they're on active therapy? We normally don't, just not because it hasn't been studied. And again, we have to look at benefit and risk. What's the benefit of this drug, but what's the risk? Could there be an interaction that we don't know about because it hasn't ever been studied? So we normally wouldn't be starting. Once patients are in kind of, they're not really on active therapy, that's really the time that we start these drugs at that point. So.
Hi, how are you? Thanks for
Good.
all the good information. I had a few questions. So I'm on my 5th week of tirzepatide with the support of my endocrinologist, and he was the one who said tirzepatide versus semaglutide. I am at a compounding pharmacy in Leesburg, Virginia. It's called the Compounding Pharmacy, and they're third-party tested as well. But my question is around, I actually am not on it because of like obesity and those things. I'm on it because I had an autoimmune flare that was I had inflammation everywhere in my body. It was impacting my cardiovascular health. It was also impacting my A1C, and I was like 4 points from being a full-blown diabetic. And that's why I started taking it. But I had a question around calcium absorption in GLP-1s. And because I am hypocalcemic, and was wondering, is there any, because I feel like I often I'm not absorbing it right now, and I feel tingly and I have to take extra. Is that common?
So, it used to be that we had a lot more patients that were hypopara. That's when we see the low calcium is that, they've had their thyroid removed and then the parathyroids are affected. It's less common because there's less and less cases as, especially as you work with surgeons that are more skilled, you'll have less cases. So we don't see as many. So there are not as many patients anecdotally that I can say that we see on both the GLP-1s and our hypopara. But I can imagine that there might be some absorption because calcium in general can be affected by lots of things. The one thing to do is maybe take the calcium at smaller doses during the day instead of taking big doses. And we do recommend that to our patients in general if they have any issues with really absorbing it. So you can take them at smaller doses more times a day than taking them in big doses, because in general, like if I was to take 1200 milligrams of calcium right now, I'm not going to absorb any of it anyway. So we always split it, but maybe you could split it a little bit more, but we haven't noticed that in general, but we may see more of that in the future as more and more patients use it.
Thank you, Dr. Khan. We appreciate your time. This
Yeah,
was very
absolutely.
interesting.
Absolutely.